Indian Health. And our center has partnered with tribes for over 30 years to support and implement public health interventions designed for and by Native peoples with the mission to promote health equity for Native Americans. In the spirit of healing, I honor the Piscataway and Susquehannock nations, the original peoples of the lands which Johns Hopkins University occupies. And I'm joining today from Southwest Colorado on land that is connected to the communal and ceremonial spaces of the Jicarilla, Pueblos of New Mexico, Hopi Sonome, and Dene nations. As we gather from places across the globe today, we honor and recognize the Indigenous people who are the original occupants and stewards of these lands. We're delighted to come together with the International Vaccine Access Center, or IVAC, which is another center in the Bloomberg School of Public Health at Johns Hopkins. IVAC builds knowledge and support for the value of vaccines to help create a world that's free from the adverse health, economic, and social consequences of preventable diseases. Since the COVID-19 pandemic began, IVAC's hosted over a dozen webinars with participants from over 90 countries. And this is one of 3 webinars IVAC is hosting during the World Immunization Week, for which the theme is Long Life for All. The theme offers a moment to celebrate how vaccines help create healthy lives from infancy through older age, which is an appropriate theme, particularly in Indigenous communities where intergenerational connectedness is highly valued. We're fortunate to be joined today by a group of expert panelists who'll tell us the story of how COVID-19 vaccines have been rolled out in Indigenous communities in the United States and in Australia, and will highlight the lessons learned and the challenges remaining to achieving equitable access. Before we get started, just a couple of housekeeping remarks. We want to let participants know that we'll have a Q&A session at the end. So please enter your questions into the Q&A box, and we'll try to get to them after the presentations. There's also a chat box, so please feel free to introduce yourself there and enter any comments that aren't questions. The webinar is being recorded and it will be available for viewing after today's presentation. And now I'd like to introduce our moderator, Jordan Bennett-Begay, who is the editor of Indian Country Today and the first woman to be the top editor of the 40-year-old newspaper and website. She's a Dene citizen of the Navajo Nation and is a Native American Journalists Association board member. Over to you, Jordan.
Hi, thanks, Laura. Yeah, thank you all for joining us for this discussion as part of World Immunization Week. On behalf of ICT, I want to thank our partners, the International Vaccine Access Center and the Johns Hopkins Center for American Indian Health, for organizing this panel. And I'm really excited and grateful to be here with these expert panelists, to discuss this very important topic, equitable access to COVID-19 vaccines for Indigenous populations. And a quick backstory for you. So I got connected with the Center for American Indian Health regarding a COVID-19 database. I started back in March 2020. The database was a spreadsheet using publicly available data from tribal nations in the US. The database is public, showing case counts and death counts and where the data originated. ICT was the only entity for some time keeping track of the mortality rates for American Indians and Alaska Natives. And from there, Johns Hopkins and ICT partnered, and now they're carrying on the project or taking care of my baby and making it a more comprehensive database. And the school's engineering team put together a map that can be seen on the university's Coronavirus Resource Center website. And since we're talking to you all, an international audience, I wanted to quickly run through a few facts about tribal nations in the United States, and more specifically, tribal sovereignty. There are more than 570 federally recognized tribes in the United States and 326 designated tribal lands or reservations, they're called. Tribes have a nation-to-nation relationship with the US government. The US Constitution recognizes that tribes are sovereign governments. It is through hundreds of treaties, plus the Supreme Court, Congress, and the president that tribes can exercise tribal sovereignty or self-govern. Tribal governments have power to form their own government structures, make and pass laws, and enforce these laws through their own law enforcement and tribal courts. And I want to explain this concept because tribal sovereignty had a lot to do with how the pandemic affected Indigenous peoples in this country, from mask mandates to vaccine distribution and obtaining federal funding to deal with the impact of COVID-19. Tribal sovereignty is part of the US government's trust responsibility to tribal nations, meaning the United States must protect tribal lands and tribal rights and protect tribal sovereignty and provide basic social, medical, and education services to tribes. And it's the last thing to keep in mind before we get started is that tribal nations and Native people in the US are very diverse. We live in urban areas and rural areas. We are diverse in government structures, languages, having land or no land, economies, cultures and traditions, health programs, and etc. And so with that, each speaker will provide opening remarks, approximately 2 minutes, sometimes with slides, followed by a 25-minute panel discussion and time for audience questions. And the event is being recorded, as Dr. Hammett said, and will be available on YouTube. And all registered participants will receive a link to the recording. And I'll introduce our first panelist, Dr. Loretta Christensen. Is an enrolled member of the Navajo tribe, serves as the Chief Medical Officer of the Indian Health Service, the IHS, an agency within the U.S. Department of Health and Human Services, is a principal federal health provider for American Indians and Alaska Natives. As a Chief Medical Officer, Dr. Christensen is IHS's lead expert on medical and public health topics, giving technical consultation and guidance to the IHS Office of the Director and the IHS staff through the country on American Indian and Alaska Native healthcare policies and issues. A graduate of Harvard University and what is now Drexel University College of Medicine, Dr. Christensen is board certified in general surgery and a fellow of the American College of Surgeons. During the COVID-19 pandemic, she served as a co-lead for the COVID-19 response branch and the medical branch lead for the Navajo Nation's Unified Coordination Group. Great, Dr. Christensen.
Thank you so much. Hey, everybody, I am Dr. Loretta Christensen. Happy to be here with you today and just briefly review a few things about the IHS. And just I was in Navajo for quite a bit of the COVID, so quite an experience there as well. Next slide, please. So here you see, I've always used this picture, one, because it's beautiful and it's the homeland, but secondly, I like to show it to people so you could see how rural it is. These are some of the things that create some of our challenges, although it does give us peace and beauty and harmony. We have to get across all of that land when we are trying to take care of people, distribute things, and provide, in this case, the vaccines that were given. Next slide, please. So this is just a brief epicurve of Navajo where I was, just to show you a pattern of how we were hit across the nation. As you can see, there were many peaks there. We did avoid a couple of them that the United States suffered, but we did certainly get it with Delta, as you can see. And then all the way to the right is our epicurve for Omicron, which was quite profound. And what we're going to find is we did predict and we did prepare and we were quite proactive, knowing our population was quite vulnerable, and we knew that they would get hit very hard, unfortunately, by this virus. Next slide. So just quick look at comparison data, and this was the most recent on CDC. I followed these all along through the pandemic, and it varied in cases up to almost 3 times the number of cases for any race or ethnicity. Hospitalizations have remained over 3 times more than the rest of the races and ethnicities. And deaths are down at 2.1 times now, but at one point it was 4 times the amount across the nation. So you can see this was quite profound, the effect of COVID on our American Indian Alaskan Native population. Next slide, please. So I like this slide because this is one of the last ones that CDC displayed this way. And I know it's hard to see, but all I want you to imagine is that gold line on top. You know, the response of Indian country was exceptional. And we're going to hear about why, but I'm going to throw out there the tribal leadership, the progressiveness and the proactiveness of all of our tribal leaders across the country saved lives and made a huge difference. because we jumped out there, because we advocated early, because we were able to secure vaccinations for the population, this made a huge difference to us because our peak of vaccinations was actually before Delta hit, which I know we would have had a lot more hospitalizations, critical illness, and deaths, but we got out there early, we hit it hard, and we led the country in vaccinations for the very, very longest time. We're a little bit flat now, but we still haven't given up. We're still out there all the time. And, you know, it's just an amazing effort across Indian country to make that difference for our people to save those lives. Next slide, please. Just some pictures, because I just love to give a shout out to all those who did all the great work. This is COVID-19 on Navajo Nation. You saw we had Navajo Nation police escort. We had our coolers, and we distributed to every corner of Navajo, which is 27,000 square miles. And we got it there on time. We didn't lose any vaccine, and we gave shots that day. So it just shows you this was a well-prepared example of the Indian Health Service, along with a lot of our partners, including Johns Hopkins, that were so helpful to us in getting this done. Next slide. Again, tribes are racing ahead of the vaccination curve. We did so well. My deepest thanks and gratitude to every frontline healthcare worker and member of the staffs across urban, tribal, and federal sites for the exceptional work they've done. And they're just heroes, every single one of them. Next slide. And then lastly, I just want to show you that we 2.18 million doses were administered in the jurisdiction of IHS. That means just those who chose us for vaccine distribution. A lot of, like Alaska, went with the state, so we are missing numbers. There's more. Okay, we figure there's about 1.3 million more doses that were given to American Indians and Alaska Natives that aren't in IHS data, but we're going to recognize that the people still got out there into those centers and got vaccinated. Next, please. So therefore, I'm going to wrap it up because it's a short introduction. I'm very happy to be here with you today. Thank you so much, Jordan. Back to you.
Thank you so much, Dr. Christensen. And our next panelist is Dr. Maggie Dutchen, is a consultant pediatrician at the Royal Children's Hospital and clinician scientist at the University of Melbourne and Murdoch Children's Research Institute. As a leader of the Institute's vaccine uptake group, her research focuses on vaccine confidence. During the pandemic, Dr. Dutchen had worked closely with the Commonwealth and Victorian state governments on the COVID-19 rollout. She has led COVID-19 projects on the impact on children's mental health and well-being, and is leading the CASI Vaccine Champions program to build confidence in COVID-19 vaccination in the Western Pacific region. Also presenting is Dr. Nari Blow. Dr. Blow is and excuse me for this pronunciation because I forgot. Dr. Blow is a Yorta and Quadamuka, serving as the Director of First Nations Health for Medical Education at the University of Melbourne, as well as dedicating part of her time to the COVID-19 response. She currently works in the COVID-19 vaccination program for the Department of Health in Victoria. Dr. Blow was most recently recognized for her work in 2020 when awarded the Australian Asian Faculty of Public Health Medicine Victorian Jerry Murphy Prize, and was named one of 2019's Australian Financial Review's 100 Women of Influence. Dr. Blow is also a board member of the Australian Indigenous Doctors Association and has been involved in many First Nations health research and education roles.
Thank you so much, Jordan, and it's a real pleasure to be with you all today, and especially it's a pleasure to be presenting some of this work with Dr. Blow. And you know, I think it's a wonderful opportunity as well to compare the experience of Indigenous communities and the response to the pandemic and to the challenge of getting equitable and high vaccine uptake between Indigenous communities in the US and in Australia. Next slide. But before we start, I would like to acknowledge the traditional owners of the country across the nation that we live, which for me is the Wurundjeri people of the Kulin Nation, and pay my respects to elders past, present and emerging, and all the diverse cultures that make up the First Peoples Nations. Next slide. So as Dr. Christensen started off with, of course, for World Immunisation Week, this is a wonderful opportunity to step back and look at the experience in Australia. And of course, data is key. The power of data to highlight inequities is so important. Here is the current state of play in Australia nationally in terms of our vaccine coverage. And I think it is really remarkable to actually sit back and see what a pro-vaccine nation Australia actually is. We now have, you can see there in orange in the bars on the right, in general, over 90 or 95% two-dose or fully vaccinated coverage across most of our states in Australia, and even higher, of course, for one dose. Next slide. But comparing to the coverage for Indigenous peoples across Australia, again, there you can see all the states listed down there in the orange. The coverage is somewhere between 10, 15, or even 20% lower. Having said that, the response by Indigenous communities has been remarkable. And you can see there, the two-dose coverage is over 80%. Lower in some states, maybe as low as 74%, you can see there in South Australia, but still a remarkable response, but that gap remains. Next slide. Both Nari and I have predominantly worked together in the state of Victoria, where I am from, even though she's currently based in Queensland. And these data show the current state of play in Victoria for Aboriginal and Torres Strait Islanders for the first and second doses for individuals over the age of 16. And you can see there again, remarkable 86 to 88%. And then the purple line down below there is the third dose coverage, or the booster dose coverage, which has now got up as high as 50%. In terms of the epidemiology, in terms of First Nations in the first year of the pandemic, the response by communities was remarkable, and the cases in most Indigenous communities were incredibly low. But as we moved into 2021, and especially as the Delta strain hit, the situation changed, and unfortunately cases really did escalate. And so the challenge around increasing vaccine coverage became more urgent. And I think what Nari and I really want to share, and I'm going to pass over to her now, is just the extraordinary response of communities and what was done in terms of communication and strengthening community engagement, and really understanding and acknowledging community distrust and what was needed to build trust in communities. And just some of the incredibly innovative approaches that were developed and that Nari herself led and continues to lead here in Victoria. Next slide. So I'll hand over to you, Nari, just to give a little snapshot around Victoria and just an overview of some of the approaches.
Thanks, Maggie. Yorubanjis, Naja Nari Blow, Naja Yorigota Bengrang Binyanyan, Naja Nunako Goreng Goreng Bunjanyan, Yoruburiba Yagara Turabo, just acknowledging in my language of my people that I'm connecting in from Yagara and Turrbal nations, which is up in Queensland, but I do work in Victoria and also I'm very much part of the Victorian community. I grew up on Wurundjeri land where Margie is sitting, and also my mother's people are from Yorta Yorta Nation, which is in rural Victoria. I understand that not everyone would know about First Nations in Australia, so I just wanted to give a quick snapshot of what Victoria looks like. We have relatively small numbers over all of Australia. 3.3% of the country is First Nations or Aboriginal and Torres Strait Islander. We have sort of led more towards the term First Nations because we also acknowledge we're very diverse as Aboriginal people and have multiple nations that make up our communities. So we are a relatively young group with really over 50% of our population are under the age of 25. So children and young people are so important in terms of engagement for our communities. And we have multiple languages across, so we can never really do a lot of these messages in one particular language. You know, Victoria alone has 38 languages and there's many more in other states and territories. So that's just a bit of a snapshot. So next slide. What we've been really focusing on throughout the pandemic is ensuring that we've got as many First Nations voices as possible. Margie very generously talked about my role in this space, but really this has come from a collective. Really, the Victorian Aboriginal Community Controlled Health Organisation has been the driver of this and has been supported by the National Aboriginal Community Controlled Health Organisation, of which we affectionately term NACCHO. And really the leaders of our communities really stood up right at the beginning of this pandemic and said, we need to be actively involved. We need a voice in this space. We need to be right at the beginning of the planning. And we had quite a lot of our leaders talk about our experience with the H1N1 influenza pandemic in Australia, and because of that experience, really we're on the forefront in terms of communication and making sure borders were shut to remote communities as well during the start when we didn't have any vaccines. We also really engaged as many First Nations spokespeople as possible, and that didn't just mean health professionals, but artists, other partners, and other, making sure that it was guided by traditional owners of Victoria. The next slide. This is just a brief note around terminology. We really made sure that we had to kind of go through a process of education within the department as well. Quite a lot of people working in the pandemic were not First Nations, and so it was really external partners that we worked with and external organisations, as I mentioned earlier, like BATCHO. And we really had to acknowledge that there is a lot of community distrust with government, as I'm pretty aware is very common with a lot of Indigenous peoples around the globe because of that relationship with colonisation. And so we wanted to make sure that the messages that were coming through were coming from trusted sources, from community voices, and being really mindful of language. We have some colloquial terms like mob, and deadly actually is a positive term in our communities. So we had to kind of be mindful of how we use that language when we were talking on these topics, and making sure we had cultural authority to speak on these topics. And really, I'm sure we're all very aware as sort of public health minded people that we really want to focus on strength-based messages and really avoid that deficit language. And as much as data is so important and thinking about, the deficit behind the vaccination rates, we didn't really want to focus on that and really want to take it away from that traditional, or get away from a sort of a government approach and really go with a community approach. And that's just one image there that's been done by a local Aboriginal artist. So next slide. We also just made sure we use really trusted, culturally safe channels. So really just making sure we were using those Aboriginal organisation websites, the national Indigenous television channels, also engaging First Nations journalists and radio stations, rather than just going out on the mainstream channels, although we did also utilise mainstream channels for some campaigns as well. So next slide. This is one sort of case study of what we did in Victoria. There was a lot of messaging about vaccination in general, and we wanted to do a specific messaging for Aboriginal communities. And so this sort of piece was done in partnership with that community controlled health organisation in Victoria around COVID safe behaviours. We actually used an Aboriginal owned and led graphic design agency called Little Rocket, and we engaged an elder and well-known actor of the Victorian community. His name's Uncle Jack Charles, and also a local Aboriginal artist to create some of this work. We really focused on the messaging of community unity and immunity, because we really wanted to really talk to the strengths of our communities. This particular campaign was nominated for a Kinaway Award, which was a sort of a local Indigenous or a national sort of Indigenous company, and was sort of televised quite extensively. So next slide. The other sort of case study we have in terms of a community-led approach is thinking about our youth and our young community. As I mentioned, majority of our community are under the age of 25. So we wanted to do something that would really engage our youth, particularly around the second shot or the second vaccination. It's interesting around language for some communities, particularly in the Northern Territory and in remote, using the term shot is not a particularly good way to use it. But in Victoria, there's in the youth community, there's a lot of praise around sport and basketball. And so utilizing this take your shot and having some footage around some basketballers was actually something that was really great. And Philly, who's a Wamba Wamba musician, actually created a rap for this video that was pretty catchy. And maybe I'll be able to play it for you later. And this was sort of actually led and run by our local First Peoples Health and Wellbeing Health Service, and also an Aboriginal owned production company known as Typecast. And that kind of got launched on national TV on the ABC and Channel 10 in Australia. And it was also just shared organically by the community, which was really great. So next slide. And finally, just wanted to talk to that third dose or that booster dose that Maggie mentioned. As you can see, it's still down at around 50%, because I think, the status of fully vaccinated was 2 doses. And so not as many, the community have taken up that third dose, but we know we're coming into winter here in Australia. And so we really wanted to engage, particularly again, our kids, our young people around this third dose. And again, we saw how popular that music video was. And so we've actually set up and partnered with a music promotion company known as Us Entertainment. And they have helped us work with the local Aboriginal health services to create a youth music festival, which is actually happening this Sunday. And then we've got 2 more happening the end of May and the end of June. And so we're going to utilize that to actually showcase a lot of these campaigns they talked about. There's also other videos where we've done myth-busting vaccine videos, which were actually based on the ones that Maggie did for Melbourne University, but we did them with Aboriginal health professionals. And then we've also created some animations with well-known Aboriginal people doing voiceovers on those around vaccine truths, because a lot of the hesitation was not just about mistrust with government, but also around, concerns with pregnancy or fertility, or concerns with, it changing our DNA and things like that. So we wanted to really bust those myths around the vaccine. And so a lot of those things that we've worked on will be displaying at this music festival on Sunday, and we'll have those local musicians there to talk not just about vaccinations, but also using it as a bit of a health promotion event, because a lot of our community, have really put other health checks aside because of the pandemic. So we've got, diabetes checks, blood pressure, hearing checks for the kids, all of those things that that really were put, to the side during the pandemic. So I think that's all the slides I have. And I just want to give you some examples for our discussion later. So thank you very much for having us.
Thank you so much, Maggie and Dr. Blow. And on to our next speaker, Tam Lutz. Tam is a Lummi tribal member with ancestral ties to several other Northwest tribes. Tam has spent over 27 years working in public health in Indian country, including over 22 years at the Northwest Portland Area Indian Health Board, where she directs maternal child health programs, including chronic disease and motor vehicle injury focused projects, research studies, and surveillance. Tam serves as a Northwest Tribal Epicenters Project Director for 2 CDC-funded vaccine-related projects, improving vaccine communication and education, including native boosts, that is addressing barriers to childhood immunizations and national tribal epicenter collaboration. And that is addressing barriers to adult vaccines. She received her MPH and MHA from the University of Washington. Take it away, Tam.
Aishka, Nautsiam, Ait Squao, Tam Senat Snat, Cha Tam Wixen, Cha Clemitson, Ait Quins Lengnonget. Hello, good afternoon, friends. My name's Tam, and it's good to see you all. Next slide. I'm here from the Northwest Portland Area Indian Health Board, and we serve the 43 tribes of Washington, Oregon, and Idaho. And while I work for those specific programs that Jordan had mentioned, here at the board, our efforts in our region involve many people across many programs in our organization and many external partners, all of which are skippered by the experiences and voices and expertise of our tribal leaders, our providers, and our tribal and urban communities. Next slide. Our programs strive to increase confidence in immunizations and increase vaccine rates, engage tribal leaders and providers, and use culturally relevant frameworks for messaging, some of which you can see on the side here. Bigfoot is a big theme in our culture and has been incorporated in our messaging. And as well as in our work, we acknowledge our history, and we remember that the populations that we serve, or the tribal nations that we may be working with, have historical reasons for the mistrust and hesitancy they may be experiencing in their communities. Next slide. And while Loretta had some great data to share with us about Indian country and what we're seeing, I think what I'd like to share is a little bit of another way of looking at data, is listening to the words of some of our community members. And what I'm sharing is a family of 4 generations. If you can click the, I don't hear the sound. Oh, that's unfortunate. So this was a great example of us listening to what the tribal members were telling us about the issues in their tribal communities. We wanted to take a look across generations within one family to talk about what motivates us to make the decisions that we make in caring for our children, for our families, for our elders, and our communities. So I guess I will provide the link unless you can get the sound on, Andrew. There we go.
In the Native American tradition, family is everything. When we're not taking the necessary steps to getting vaccinated, it makes it harder for us to be together and then carry on those traditions.
Being able to receive a vaccine, whether that's the flu or for COVID, it gives us that opportunity to be able to be in a space like how we are right now, to be able to share together.
Our parents and grandparents, they encouraged vaccinations to protect themselves and their families. If everybody did that, we'd be a better world. Thank you.
It's an amazing feeling to watch generations come together and take care of each other. Being with family means everything.
Did you wash your hands?
So I just like sharing that video because I think it talks to what motivates us and what inspires us. You know, we always talk about the 7th generation, and that we want to be able to, years later from now, to think about how we cared for our family and how we cared for our communities. Thank you. Housekeeping.
Thank you so much. Sounded like my grandma at the end. Thank you, Tam. And our last panelist is Joshua D. Allison Burbank, who's Danette Acoma Pueblo. He is an assistant scientist at the Center for American Indian Health of Johns Hopkins Bloomberg School of Public Health, based out of the center's Albuquerque, New Mexico regional office. Joshua is a licensed speech language pathologist and previously worked at the Northern Navajo Medical Center in Sebetat on Navajo Nation. Dr. Allison Burbank received his master's in doctoral degrees from the University of Kansas, where he focused on neurodevelopmental disabilities and prevention research. All yours, Josh.
Thank you, Jordan, and Yate to my panelists and to everyone joining this afternoon, this evening. Yate Shea Joshua Allison Burbank, Shea Kluganishlan Kisani Bashishi, 200 Dashache Kisani, Dashanala, Akut Ego Dinet Do Kisani Hastin Nishla. Giving you a nice warm virtual handshake hug from right along the beautiful Rio Grande River, which is on ancestral Tiwa lands. And I'm here to just share a little bit more about my work and part of this large, vast effort to meet the mental health needs of Diné and Apache youth as we move forward in pandemic recovery and help students to safely return to schools. Right now, my research is focused mostly with COVID pandemic response. I'm a developmental scientist by training, and my work really focuses on the social determinants, the social cultural factors, and also present day traumas, and in this case, a pandemic, and how that is impacting Native student learning, Native student resilience, and looking at those facilitators and those barriers to help with long-term pandemic recovery amongst our most vulnerable population, which is our young Indigenous youth. Right now, I'm working on a study that's assisting with implementation of COVID pool testing in partner schools across the Navajo Nation. There's also a research component to that study where we're aiming to measure the mental health burden on school-age children between the ages of 4 to 16 in Navajo and Apache youth. And we're using that data to really plan on immediate mental health supports that we can deliver to the schools to help meet elevated distress, any indication of suicide risk, but also to use this information to look at how do we long-term partner with schools, tribal leadership, and various public health entities to implement best supports to our Native students. Some other work that I'm doing as a developmental scientist and public health professional is starting to look again at our most vulnerable population, the early childhood population, which when schools shut down and in-person early childhood resources ceased, that meant children that relied on families that relied on parent coaching, children that relied on playgroups and other developmental supports, special feeding clinics and various other specialty clinics lost connection to that momentarily as all efforts shifted towards COVID response and emergency care and other types of public health efforts. Now that we are looking better and we're being quite resilient in the work that we're doing, and we'll talk about this later about how these mitigation strategies are continuing to protect our Native population so we can move back and really focus on recovery in our most vulnerable population. And so a new study that I'm working on is looking at the high rates of developmental delay as a result of the pandemic in Diné toddlers and early childhood populations, and using these interventions targeting developmental delay to also look at family stress if it's elevated in Diné families across the Navajo Nation. So I'm here to talk about what next? What do we do next? But also, how do we still work towards and contribute to mitigation strategies? How do we address vaccine hesitancy again for our most vulnerable populations? And also, how do we help to continue educating our parents on the need for continued precautions and thinking about how vaccines, how masking, how the various mitigation strategies are going to be important over the next few years as we think about prioritizing the health and wellness of our Native youth. So it's a pleasure to be here. I'm excited to talk more about my work, but also to hear about how we have made different changes and progressed and showed resilience from immediate response to direct care. And now we're moving towards recovery efforts and maintaining some of these mitigation strategies. And so thank you, Jordan, right back to you.
Thank you so much, Dr. Allison Burbank. And thank you for all for your short presentations. We are not close to time, but we're going to have to maybe have our answers be like under a minute. So it's our challenge. The first question, and I think we kind of addressed it earlier, and this is for Dr. Allison Burbank and Tam. How did Indigenous sovereignty help with the pandemic response in terms of like laws and policies when it came to borders, curfews, and masking?
Tam, would you like to go?
Sure, I can go. Let's see. So I think in terms of, this is the tribal sovereignty question.
Correct.
So I think in terms of tribal sovereignty, not only did it help initially, sorry, I lost my, what was going on here? Okay, it helped not initially that tribes had this government to government relationship with the federal government, and initially could decide, how they wanted to receive vaccines, whether it would be directly from IHS or from their state departments of health. But it also meant that tribes could develop their own policies or practices, restrictions that were specific to the needs of their own community. And we're not necessarily privy to the same kind of political pressures that maybe the states or local jurisdictions around them had to encounter. And so as I think as Dr. Christensen said, I think it really saved lives because we were able to immediately assess what was needed in our own communities.
And to add on to what Tam said, I think what was so key and so powerful throughout these early surges, and even now, is these Indigenous values of kinship and family and respect for your neighbor also contributed to these high compliance rates across the Navajo Nation. I feel like that's what's unique to Indigenous communities across Indian country, is this respect for one another, this kinship that we talk about often in Diné culture and Pueblo communities as well. Is you're doing it for yourself, but mostly you're doing it for your relative, you're doing it for your elder, you're doing it for other members of your community. And so that mentality of that collectiveness and that respect for your community, I feel like meshed very well and allowed and assisted public health professionals to be as successful as they have been. Still much work to do and addressing hesitancy, but I feel like that approach of talking about responsibility to community combined with tribal sovereignty has really allowed for a model of what we can work towards as public health professionals. And so again, just very happy with the response of my people, the leaders, those working on the ground, mutual aid organizations who all stepped up as part of this collective effort to take care of our most sacred elders, immunocompromised people, the children who are yet to be vaccinated. And now as we shift towards continued vaccinations, that tribal sovereignty and that continued respect for one another is going to help us and really allow us to work towards getting rid of the Gosensagi at some point and getting out of our communities.
Thank you so much. And I think that's the collective similarity, in Indigenous populations is the community-oriented approach, whether it was distribution or messaging. Thank you. And this is for Dr. Maggie, Dr. Blow, and Dr. Christensen. I was curious, what are the coverage disparities of vaccines now in Indigenous communities? Where should the focus be directed at this time, 2 years later?
Thanks, Jordan. I shared a little bit at the start some of the coverage data of where we're at the moment. And as Nari said, we really like to focus on a sort of a strength model rather than a deficit model. And there is a gap. And I think it's important for us to recognise and remember that and really target our strategies. Be interesting to hear what Nari feels. I think at the moment, we do have a big challenge with the vaccination of children. Our response of the sort of 5 to 11-year-olds as we've seen globally, has been lower than we would like. And I think nationally now we have sort of 58% of kids have had 1 dose, and it's around sort of 35–40% maybe have had 2 doses. So I think vaccine coverage for children remains an issue, but very much around booster doses, 3rd doses, and now even we've got 4th dose recommendations for high-risk people over the age of 65. So there are still gaps, and I think my sense is that, you know, the gaps are across mostly in young people, I would say. The coverage is definitely lower in young people, and Nari can speak to that, but also still amongst the elders, that I think there's still some work to be done. Nari?
Yeah, thanks, Maggie. It's actually interesting when you're talking about Indigenous sovereignty, because sovereignty has never been ceded on any of our nations in Australia. So for us to be involved in this response, it was really a case of me seeing people I very much respected and leaders in our community really pushing their way into this, to be actively involved and constantly advocating for our communities. But luckily, you know, as Dr. Alison Burbank said, you know, Indigenous peoples do have that community mentality of wanting to protect our elders, wanting to look after our community. So a lot of the COVID safe behaviours were things that were very much, you know, something that we supported each other in doing. But when it comes to vaccination, yeah, there's this, as I've said before, very much this mistrust. So that's why we just have to, we can't become complacent and just say, oh, we've done our campaigns now and this is where we stop. And that's why we've got, you know, these music festivals coming up, and these, you know, we're going to continue to do this advocacy and campaigns from, you know, community controlled health orgs, so that we're continuing to get the message out of the importance, particularly around winter, knowing that a lot of our community have high rates of chronic disease. And, you know, as Margie said, there's this 4th dose for over 65, but that's actually been lowered to over 55 for Aboriginal and Torres Strait Islander people, because knowing that, you know, our life expectancy and knowing the social determinants have such a huge impact.
Yeah, hi, Dr. Christensen. Thank you for that. You guys have some really great data and really great insight. So I'm so happy to be here with you sharing it today. But for us, you know, we did take off pretty fast, pretty early, and we were very pleased with that. And it was very protective. We have hit a rather plateau, and it varies from area to area. Remembering we serve 574 federally recognized tribes, there is going to be variance there. The point about trust is very important. We had to build trust very early, even in the development of the mRNA vaccines, because it was new. It was so fast. It hit the ground so immediately that people were like, "Are you sure this is okay?" Well, yes, as best as we can. This is great science. And they've turned out to be very good vaccines for the time period in which they're developed. So it's incumbent upon us across Indian country to look at those areas that did very, very well, which was Navajo has some incredible, as Josh was saying, incredible vaccination rates in all age groups, even the younger, and definitely succeeded across Indian country in our elders. We have been very, very progressive and pushing very hard to protect our elders, our history, and our relatives. But I do think it is the younger age groups. I agree with all of you. That is going to require our effort and our focus. One would think maybe that would be easier because they're in school and we can capture these age groups. And actually, it's become a bit more challenging. So we're pulling out all different best practices. I do encourage all of the tribes to share with each other. You know, I said, ask Navajo how they did it. They somehow got this together through their leadership and their community and all of everybody that pitched in there and really did an amazing effort, and that could be replicated. But I always think the one I would tell people is remember that over 70% of the Indian Health Service is also American Indian and Alaska Native. So it is not just a government entity saying get vaccinated. It's our own people helping our own people get vaccinated. And I hope that created some trust and some compliance out in the field that we're all related, we're all from the same communities, and we're all trying to take care of each other. But that would be our take, is to retool and get out there with our best practices again and try to get the rest of our areas up to the best level possible. Thanks.
Thank you. And for those watching, before we get to your questions, please put your questions in the Q&A box. I have one more question before we see what rolls in. And this one is it's a concept that I've been really curious about, and that's herd immunity. So maybe Dr. Christensen, Dr. Dutchen, or Dr. Blow can answer this. And several months into the pandemic, many experts were saying we need to reach around 60 to 70% herd immunity. But I was curious what the recent talk is around that, because it seems to have evolved in the last 2 years.
I think maybe I'll have a go first. I think it's really interesting. At the start of the vaccine program, there was a lot of discussion around herd immunity, but that conversation has changed now because the vaccines are not as effective at preventing transmission as we would like. They're pretty good. We saw about a 50% reduction against transmission in vaccinated people with Delta, but with Omicron, that's been less. It's been more like 30 to 40%. So I think the discussion really needs to focus on the main aim of the vaccine program is actually the prevention of severe disease. So we do want people to protect themselves and to make sure the people around them are protected, but the impact on transmission is less. So it sort of comes back to the COVID safe behaviours as well, and that vaccines are only part of the strategy. The pandemic's not over. We do need very high coverage. It still has an impact on transmission, and that's important. But sterilizing immunity, horrible term, but that really sort of blocking of transmission, unfortunately, has not been achieved by these vaccines. And I think that has been a really complex message for people. People have been confused about the impact on transmission and what it means. But I think it's really what we have seen is these vaccines have been really good at keeping people out of hospital and from dying. And that's an important message about protecting our communities and people from severe disease.
Thank you so much. And Dr. Christensen, did you
I'm just going to jump in super fast. Absolutely agree with Margie and appreciate her answer. But I do think that when people were thinking herd immunity, at least it was a focal point early in the pandemic. Let's work towards this. Let's protect our communities. And then, of course, this virus has been so elusive, so evolving at all times with these variants and subvariants. We couldn't know what was going to happen. So I think that now we focus on how do we do this in a controlled manner, get people vaccinated. And then for me, I like to go a little slower, opening up everything. I'm still a little hesitant. But that herd immunity is not really the goal. The goal is just keeping people as healthy as possible, and then dealing with each of these variants and changes as they come along. So I think our focus has just changed. Thanks.
I appreciate that. And I guess there's no questions in here from the Q&A box, so we'll go through everyone real quick in 30 seconds. What is the one lesson learned going forward?
Nairi?
I knew you were going to make me start. There are so many lessons, but I think the strong lesson is that our communities have been looking after each other for over 60,000 years here in Australia, and we know how to do it. And once we're given the opportunity for self-determination and being sovereign to our own health experience, that's when we see positive outcomes for our peoples, particularly in this pandemic.
I'd like to echo that as well. For me, I think it's been such an extraordinary privilege to work with Indigenous leaders and communities. And for me, the power of community engagement has just been so apparent, and strong communication and what you can achieve, and listening to people's questions and responding and respect. It's just been so incredible. People don't necessarily want to consume information on websites and fact sheets. They want to ask their questions. They want to personalize it to themselves and to understand what it means for them and their family and their community. And so open forums for discussions, yarning. Nairi and I have had the opportunity to run some really fantastic webinars for Indigenous healthcare providers, parents, communities, and just really listening and responding and building that relationship further for people like me, and trust and respect has just been so important and really just a privilege, as I said.
For me, I think the message is the strength and resilience of our Indigenous populations and communities demonstrated that somehow those with the least always do the most incredible things. And we came together because we respect the earth, we respect each other, and we respect the blessings of life that we have. And we just kept together to get this done. Thank you.
And for me, it's been a very humbling experience being a member of the community and coming back to work for IHS and now stepping into public health academia, is to see how leaders step up and to see how there's these different skill sets that had naturally prepared healthcare workers to step into this space when they knew their community. Folks like Dr. Chris Percy in Shiprock, people like Tanya Lewis, a social worker in Acoma Pueblo, who knew her community well, knew how to have a connection and meet people where they're at in a safe way, to be able to start the testing at home, to be able to eventually move towards home-based vaccine clinics, and then to get the community buy-in to have these large and mass vaccination clinics. And so I feel like that takes public health training, but it also takes communal mastery, knowing your community, knowing where to go, and also being able to bring in the right people to, again, impact behavior change and get that momentum going. And so for me, that's been the biggest learning experience, is that Native people, allies working with an Indian Health Service, when they have been working for so long in these communities, they know where people are, they know how to make those connections. And so again, that collective effort and that kinship that exists amongst schools, amongst the tribal epi team, and now people who have been working with Indian Health Services, that's been what's been most powerful and impact for me as we think about the vaccine work, and now thinking about pandemic recovery efforts in the schools and trying to meet the needs of youth now. And so that's been a major takeaway for me, is that there's already knowledge and skill sets amongst our frontline workers, and let's go to them to support them, meet their needs, but also to take the skill set and the knowledge they have to meet the needs of their communities.
And Tam?
Yeah, two things. I think along the issue of resilience and our ability to be creative. It's not the first time that we've addressed a health concern like this and responded, for our tribal nations. I was able to dig up things that my grandmother did to fight polio, when she was collecting nickels and dimes, and the community was contributing in any way that they could. It may not seem like a lot, but it was the buy-in of the community. And that's what sometimes has made the greatest change, is that it's folks that are willing to help with transportation or delivering meals, and keeping ahead of the communication when there is misinformation out there, and having folks in the community that are willing to be those individuals to effectively communicate in a way that's meaningful for tribal members. And I also think that our ability to remember to meet people where they are, and to know that, we may really want somebody to get vaccinated that day, but we have to understand the context in which that person, the history of that individual, or the experience that they've had, and to continue to be there to, prevent harm from those individuals, and hopefully will, eventually they'll come back and be vaccinated. But yeah, I think those are the biggest lessons for me.
Jordan, do you mind if I just make one quick point that I meant to say? And that's, in addition to building confidence and addressing hesitancy, overcoming access challenges has been so critical alongside and taking vaccines to the people. I love Dr. Christensen's first image, which was of that remoteness, and we have the same here in Australia. Australia is a huge country and is very remote in parts. And so mobile vaccination vans, community vaccination clinics with yarning sessions. Many strategies have been done to improve access. And I think that's also been a really critical lesson for us to learn.
You're definitely right on that. I mean, I agree with all of what you said. I mean, I've seen it since the beginning. But thank you for all of you and all that you do and continue to do, and again to our healthcare workers and other scientists who continue to tackle, the COVID-19. Now we're out of time, so I'm going to hand it over to Dr. Hammett.
Thank you, Jordan. I think one thing that I just kept reflecting on while all the panelists were speaking is that it's one thing to be passionate about vaccines, and it's another thing to be in the community doing the work, getting vaccines into arms, and all of the work that it takes to do that. I appreciate all of the stories from the panelists and their insights on community engagement, on strengths-based messaging. I think the strong record of vaccinations and public health in Indigenous communities is multifactorial. Certainly during this COVID pandemic, coordinated logistics were a huge component of that, and tribal leadership. But I think fundamentally this has always been rooted in tribal sovereignty, and it's been rooted in the deep reservoirs of strength and respect and connectedness that so many of you spoke to today. It's really the people getting the vaccines who we have to thank for all of the success that these programs have had and the lives that have been saved. As we wrap up, I think, we know our work is not done. There's going to be continued work to improve messaging, to build vaccine confidence. We know that we have to strive for high quality representative data and advocate for equitable access to vaccines, because it's the data that helps us to be able to do that advocacy. And we also know that we need significant investments in Indigenous communities to facilitate a sustained improvement in all of those social determinants of health. Unfortunately, vaccines are not going to be the end all be all. They're going to save a lot of lives, but we really fundamentally need that investment and those resources to come to Indigenous communities. At the end of the day, building the capacity of Native Americans to lead health, public health, healthcare, biomedical research in their communities is going to be the most impactful way to promote health equity. And I think, just as one final plug for Native scholars who are on the line, there is a Center for American Indian Health July Public Health Institute. Registration for that is now open, and we've welcomed over 1,700 scholars to that, or 1,700 scholarships to people in that program over the past many years, representing 48 tribal communities in the US, as well as scholars from Australia and New Zealand. And one thing that I hope will potentially come out of this webinar is that we can build a shared repository of resources where we can, watch the beautiful video that Dr. Letch shared. And I know that our colleagues from Australia have also made some messaging, and I think we can learn from one another and build on one another's success. So with that, I'll wrap up and just thank you again to Jordan Bennett-Begay for moderating this session, and to all of our expert panelists for joining us today. Thank you.